Right, well, good morning, everyone. Thank you very much for joining our webinar today on postural management, a problem-solving masterclass. So we'll be covering a lot of different content today. For those that don't know me, my name's Tristan, and I work at Vivid Care. And a little bit about Vivid Care before we start. So we're a family-run business, established in 1972. So time, but we've been breaking out specialist seating assessments for well over 30 years now. So specialist seating is something we're very passionate about. They're all made in Britain, so we're supporting local manufacturing, and it means that we can very much customize whatever we need to do to make sure that people are as comfortable as they possibly can be. And we work a lot in the hospital sector. Our chairs are actually used in 80% of NHS hospital trusts throughout the country, but we also do a lot in the community as well. So doing assessments, and we've got a lot of private individuals in our chairs too, each day. And we've actually we export a lot of the chairs as well, so we've got them all over the globe in every continent, I believe, apart from Antarctica. And we're trusted by over 19,000 healthcare professionals in the UK and beyond. So we're very much involved in chairs on a daily basis, and as I say, it's something we're very passionate about. Getting someone out of bed into a chair, the difference it can make to their life is astronomical, really. We can prevent deconditioning, we can improve quality of life. But I think one of the most important words for me personally, and for us as a company, is this word comfort. And I think a lot of people think, that's not a clinical term. Why we're talking about comfort. But, if we're not looking at comfort in people's chairs, for people to think, why are we doing what we're doing? A key part of getting someone seated correctly, what we're doing is cover. Right, all those kind of things, they all should lead to comfort. So really, where we try to start off and kind of seating conversation, whether that be a seating, that be a supply of chairs to a multi-user environment like a hospital, comfort. So the way this webinar will run, sorry, there's obviously some sound issues here. I'll try and sort that. But the way this webinar will run is that we'll go over to Joanne now, who will go through the main part of the presentation, and then we'll go down into the video room and we'll go through some practical considerations, go through some of the chairs, including our Cove Care chair, and then we'll come back and do a Q&A section at the end. Apologies for the audio issues, folks. We'll move over to now. Over to you, Doc.
Hi. Thank you all for joining. There's been an awful lot of interest in this, so I hope everyone goes away with useful information and content that they can take back into their daily work. So I've been an OT for over 33 years and currently work within a NHS wheelchair services team lead part-time, and part-time I work independently, carrying out independent seating assessments in a range of settings for a range of clients, and do some education work. Lucky to be invited to be doing this today by Vivid Care, so thank you for that. I'm very passionate about posture, pressure care, and finding the best solutions and outcomes for every end user, and also about sharing my 33 years of experience and knowledge by engaging with webinars like this and running training sessions. Thank you. So I'm going to cover, this is the rough objectives of today. So always importantly, why do we need to carry out seating reviews? So assessments are the beginning of our process. As we know, we assess the client and end user with the correct seating, decide what their seating goals are, what's achievable, and how this will lead us to the correct product. But seating reviews are equally as important as seating assessments. So I'll keep coming back to that. We'll be looking at problem solving, what is and isn't working. So it's great to know what's working, but if we don't know the little parts that aren't working, we can't get to the best end solution, which is what our goal was at the beginning. So we always keep coming back to our therapy goals. What can that person achieve? Have they got the right equipment? And what can I do to help make the most of that equipment? Is the current seating meeting their postural needs? So that's always an important question. So it's not a failure as a therapist if you've prescribed a seat, a chair, or any piece of equipment actually, and then following a review, it's no longer working. So it's sometimes that their condition has changed, they've deteriorated considerably, or they've improved. So just being really clear and confident about the current seating and is it meeting their postural needs today when you're reviewing them. It may have met their postural needs when it was prescribed, but their needs can change. Then understanding what is causing discomfort. Quite rightly, as Tristan said at the start, we both are really aligned with this, that we want to normalise using the word comfort as a word that should be at the top of our agendas when we're looking at correct seating provision, and not hiding behind the word comfort as not clinical enough. And always setting realistic seating goals that will run throughout the webinar. And that's what I'll keep talking about and getting on my soapbox about. Okay, so that's what I hope to cover in this webinar today. Thank you. Next slide. Just going to have to get rid of this box at the top, sorry. So what is neutral posture? So neutral posture is a term that you'll read in textbooks. It's a term that we'll refer back to when we were students, whether we're OTs, physios, nurses, it'll all be always aim for neutral posture. So neutral posture is very individual to each person. So it's posture in which the person's body is well aligned, stable and balanced. So just keep those points in your head. It's a posture where the body doesn't need to work too hard to maintain sitting, because if you have to work too hard in a seat, then that becomes the activity in itself. That becomes the task. Sitting, we're not providing seating for a therapeutic sitting balance session, are we? We're not looking at working with somebody on a plinth. We're providing seating that will help them feel balanced, in control, comfortable, and that a posture that they don't have to work hard to maintain. Neutral posture does not put the body at risk of body shape damage. So body shape is a term I'll use a lot because everybody's body shape is individual to them. What underlies their body shape will be orthopedic things that are going on, orthopedic presentations, and that will affect their body shape. So in a neutral posture, the body is ready for activity and function. The body is ready to carry out everyday meaningful tasks. And most importantly, in neutral posture, everybody is unique and has their own neutral posture. So the days of 90, 90, 90, which were textbook, aren't very realistic. And not many of us, if we look at how we're sitting now, when we're sitting listening to this, we won't really be sitting at 90, 90, 90. So let's rethink what we mean by neutral posture. Okay, next slide. So we're looking at preventing medical complications. So poor seating can lead to pressure injuries or pressure ulcers that are avoidable. So we know that in the seated position, there are peak pressures that can be avoided if we have the correct support surfaces. This webinar isn't going into too much detail about pressure ulcer, pressure injury prevention. That has been covered on a previous webinar that I did and many other webinars and trainings, but just keep touching on it a bit today. So poor seating can contribute to poor circulation and compromising lung capacity. Let's think back to our anatomy and physiology training. We know within and underneath the ribs, within the body structure, we have crucial internal organs, cardiovascular and respiratory systems. If our spine trunk is compromised because of poor seating, then we are going to limit the capacity of lungs, and we're going to be potentially compromising heart and lung function because of fixed spinal deformities that may have been able to be prevented becoming fixed if correct seating was provided earlier. Poor seating can increase the risks of recurring chest infections. So somebody who has limited lung capacity and poor posture, they're more likely to have, in these difficult winter months, recurring chest infections. We know what recurring chest infections can lead to. They can lead to pneumonia, especially in the more complicated conditions and elderly population. So the clinical selection by an experienced healthcare professional, that's hopefully all of you that are watching today, or majority of you that are watching today, can reduce the risk of avoidable health complications. So let's keep that at the forefront of our minds. Okay, next slide. So when we talk about seating, we have to just recap about the pelvis. I always have my pelvis with me. We all have a pelvis within us as well. So the pelvis is the foundation of seated posture. The pelvis is inherently unstable, and unless supported correctly in seating, it's where the problem begins. So if we look at the pelvis here, we will see it's an unstable structure. So it needs to be supported, or it will be moving and wobbling all around. So if I was to sit this pelvis on a firm piece of wood now, it would be very unstable. So we have to have the correct contours to support the key bony prominences, the ischial tuberosities, and to hold that pelvis in a stable, supported well. The position of the pelvis when seated affects the rest of the body. The pelvis is dynamic, it reacts to changes in posture, and helps the body feel balanced and secure. So I will keep coming back to the pelvis throughout this. Okay, next slide. So moving on from that, I've just said how unstable the pelvis in its shape is. So in contrast, if we look at the base of a triangle or of a pyramid, that is very stable. So I like to use this illustration and think of the body in segments. So at the base of the triangle, we need to make sure that the pelvis, thighs, and feet are placed in a stable position. That will give us our stable base. So when we're starting a seating assessment, seating and going on further to a seating review or a seating handover, we need to always think, is the bottom of my pyramid safe? Is it stable? Is it providing postural stability to enable function? Then moving up into the next section, if we think of the trunk, the shoulders, have we got stability to be able to move? If that section is well balanced also, sticking in our pyramid shape, in our pyramid idea, we can have optimum movement in that trunk. So if we think of good proximal stability, so we're stable nearby in our body, but if we have optimum stability in the segments, we have good distal stability, so we can reach out of our base of support, we can reach to our side table to pick up a cup, we can have more freedom of movement in our head, hands and arms. So the top of the triangle, the top of the pyramid, will have optimum functioning, so optimum independence in head movement, eye movement, communication, using our hands for activities, but only if the other two parts of the pyramid are secure also. So adapt for when posture improves or deteriorates, and keep coming back to have we got all three segments supported, and are we giving the most potential for postural stability? Okay. So postural stability, leading on nicely, is controlled by different muscles working together against gravity. So two illustrations here, one from the back, looking at somebody with a scoliosis, how that may present in a more later stage, more complex scoliosis. So they'll have poor ability to maintain a seated posture without adequate support, which can result in sliding forwards in the seat, which we'll come on to a lot later. And I'm sure this is an everyday thing that we all have to deal with. Slumping to the side, leaning heavily to the side. Our body will follow the spinal curve. We'll see that individual will be fixing for stability. So they might be leaning really heavily on the armrests, arm supports, because their arms then won't be free to carry out their functions and their everyday tasks. They will fatigue quickly. And in the long term, this will lead to postural deformity and really compromised independence and quality of life. Okay. So how does the provision of correct seating increase independence? Well, the OTs in the room and many other healthcare professionals, when we go and assess our clients, it will be they would like to be more independent. They'd like to be able to do more for themselves. And that could be the smallest activity of picking up a cup or just turning to talk to somebody when they have a visitor or when a family member comes to see them. But everyday tasks we know include eating and drinking, improving verbal, non-verbal communication. It helps for better self-esteem, mental health and autonomy, and helps that individual reduce the reliance on caregivers, because many people, they won't have carers with them all the time. They may only have 2 care calls a day. Some of them will have 4 care calls a day. So in between that time, we want to know that they're in a good position when they're in their seating, that they can be as independent as possible. Okay. So coming back to the pelvis is always the key place to start and to revise the pelvis, because you can't go over this enough, and nobody should ever feel silly for not understanding about the pelvis. We work with a lot of different levels of experience in seating, so I think it doesn't do anybody any harm just to revise what is going on with the pelvis. In the picture at the top, you can see a postural assessment taking place on a seated block, and that's where we're feeling for, is the pelvic obliquity and is the pelvic rotation. So it has to be a hands-on examination. To feel this, we're always asking for consent to put our hands on another person. So let's just recap. So if we look at the pelvic alignment to start off with, that's a forward view. A lateral view is easier to see. So forward pelvic alignment would be like this, and it would be called anterior pelvic tilt. You will see this in some conditions more than others. A backwards pelvic tilt, posterior. So we'll be loading here on the sacrum coccyx, and then coming back forwards here, one side raised up. So that would be pelvic obliquity. And that's in the picture. You can see that one thumb is higher than the other. So that would show that we're raised higher on one side than the other. And then if the pelvis is forward rotated, that would be pelvic rotation. So by putting our hands on key points on the pelvis, the ASIS, we can feel the bony prominences and we can feel if there's rotation. So the bottom pictures, the first picture there on the left shows pelvic rotation, and the second picture shows pelvic obliquity. But you can't really see that unless you're getting your hands on with people and actually palpating their pelvis. It's easier to feel on a smaller adult or a child than it is on a larger adult. And be careful with the elderly. They may feel very chronic pain in the pelvic and hip areas, and they may be quite scared when you go to examine them, and they may not have had that done for a long time. So we'll always say, I just want to feel your pelvis. I just want to see what's going on under your clothes. You've got big jumpers on today. Could I just gently push up the jumper and could I feel your pelvis? So it's such an important part of the assessment and of the review. Okay. Next slide. So how do we support the upper legs and femurs? So the position of the thighs or femurs are fundamental components of successful seating outcomes. So we would like to think that everyone can sit with neutral hips. So that's where their knees will be hip distance apart and their legs will be beautifully aligned. But we know many of the people we are working with do not find it easy to sit in that position. So the goal should be to keep the thighs as horizontal, flat as you can, so that there's comfortable and equal pressure under the seating surfaces. So the seat cushion is providing a good support surface for their thighs. You will often see this isn't the case in your initial assessment or when you're reviewing somebody. Aim to maintain the thighs in a neutral midline position. So the knees should be slightly apart. So just if you look at your own seated position now, your legs will fall. They won't fall with your knees tight together or your legs very wide out. They'll fall just with a natural hip width distance between the knees. So that's what we're aiming for whenever possible, and using supports to create that if we can. Okay. Slide. So these are the posture presentations that will make the goal of neutral alignment more difficult. So we know that we need to work with the correct equipment and the correct accessories within the equipment to support the legs as much as possible. So in the top picture, we can see that there's pelvic rotation. So one side of the pelvis is forward to the other. And you can clearly see this if somebody, it may present in that, oh, they've got one leg longer than the other, but it rarely is that unless there's been a complication with a hip dislocation. And then there will sometimes be one leg longer than the other, but it will usually be that their pelvis is rotated, which will make it feel like their one leg is longer than the other. So just sitting now, if you twist your pelvis, rotate your pelvis, you will see it naturally makes it look like you've got one leg longer than the other. So we're always trying to see if we can align their pelvis back to neutral so that it isn't rotated. In the second picture, the middle picture, that illustration is where somebody has got abduction. So no, my picture is correct, but my wording is wrong. So that's something I've just spotted. So yeah. So in the middle picture, they've got your legs are pushed together tightly. There's adduction and internal rotation. So in this image, it's often due to high tone, increased tone, or it could be due to hip complications. So we'll know that looking at them in our assessment and later in our review and setup, that we need to gently bring those legs into a more neutral posture. So we'll be often using a build-up in the contour cushion, or if it's more complex, we'd be looking at using a pommel to break that pattern down. With the elderly, they can sometimes find it too much to cope with the addition of a pommel, so it will often be kinder to use a contoured cushion or a softer support rather than a pommel. And then the bottom picture is where we've got abduction and external rotation. So again, this can be for many reasons, but we want to align their legs back into a more neutral, where we've got a narrower position. So we'll have to use thigh guides. We'll have to make sure that the seat is the correct width, so it's not allowing them to do that. So these are the three presentations that can make aligning the femurs more difficult. Okay. And then moving on to spinal presentations in seating, as we saw in one of the earlier pictures, scoliosis can present in many formats. And when a scoliosis becomes more complex, it can take the S shape. So if you look at the second picture, you can vaguely see an S there. So you've got a double curve. You don't always have a double curve with a scoliosis, but this is more complex. So you have got the double curve. And what you need to decide in your assessment, is that a fixed postural presentation, or is it still flexible? So if it's fixed, we're going to be accommodating with comfort, with padding, with different back cushion options. And if it's flexible, we'd like to use a little bit more aggressive positioning, potentially laterals to push more, to give more support and more force to align. But if it's fixed, it's fixed. We're not surgeons. We're not going to go in and do surgery when we provide our seating. So scoliosis definitely will change the body shape and the options of what we can achieve in seating. So when we're looking at children, the scoliosis is often flexible, even in young adults, but as the body ages, as we lose the ability to change that shape, it will become that we're working with those more fixed scoliosis pictures. And we're always aiming for a straight spine whenever possible, but that's with a lot of the population that we're working with, that they will have gone beyond that situation. Okay. So the next spinal presentation will often be presented with in seating for adults and older adults particularly, is kyphosis of the spine. So if you look at the first picture, that's how majority of us would be seated, standing even, that it pictures in standing. But then the middle picture is when we've got the start of a kyphosis, and the third picture is where we've got a more complex kyphosis. So kyphosis will occur in the cervical and thoracic areas of the spine, so the neck and the upper back. And it is a difficult posture to work with and support in seating. We will see this in many elderly clients. We'll particularly see this in some conditions. I work a lot within my role at the wheelchair service, very sadly, with motor neurone disease. And this condition of the spine, this presentation, kyphosis of the spine, is actually really common in motor neurone. So we have to understand what we can and can't support. We need to support the trunk to make that individual feel stable and comfortable, and we need to give space for the kyphosis. So when I go and see people in care homes, residential homes, they're often sat in a upright seat that's been purchased for many people there, so like a bedside type chair with a firm back. Putting somebody with a kyphosis into a seat with a firm back will just push them further away from the back. They need to be able to immerse into the back. They need space for their kyphotic spine. You need to give them room. You need to have cushions with a lot of back cushions within your seating, need to have space to immerse into. If you're looking at some seats with tension adjustable straps, you need to loosen the tension adjustable straps to give space for that kyphotic spine. If you're going against a flat, firm back, you're going to push the person further away. And then it will become so difficult for them to maintain an upright head position, and for eye contact, communication, swallowing, everything becomes very complex when we're working with later stages of kyphosis. Okay. So just recapping really on supporting the trunk and spine. Providing support for the trunk and spine is essential for comfort. Comfort again. It's stability and function in seating. So we'll always look to fully support the trunk and align the spine in optimum position. What do we mean by optimum position? We mean the best position that's achievable for that person. One person's optimum position is very different to the next. So you're the clinician, you're deciding what is the best I can do for this person with the tools I have, the equipment I have to choose from, and my knowledge of seating. So how can I make sure that this person's spine, trunk is supported? I need to use my problem-solving skills. I need to use my investigation skills. What do I understand? What am I seeing there? Is their spine leaning? Is their spine correctable? Is their seat too wide? Is their back too flat? Is their back too firm? So you have to just go in there with your toolbox of clinical reasoning skills wide open and never rule anything out. Because when an individual feels unsupported in seating, they will see, and we see it too often, that they won't want to sit anymore. The effort of sitting becomes too great for them, too big a challenge. And then you'll see the person where they're choosing to stay in bed. So they'll become somebody that is nursed and cared for in bed, in a profiling bed, which you can change their positions, but it's not the same as seating. So the client will feel they've given up on seating, when really all it needed was somebody to go in, problem solve, and just work with them in slow stages to get them back into a more supported seating position, one in which they don't feel it's too much effort and they don't fatigue too quickly. Somebody who sits for 10 minutes then wants to go back to bed, I would be asking what was done before they went back to bed. Did anybody change the angle? Did anybody ask where they were uncomfortable? But if somebody's just put back into bed after 10 minutes, they're never going to build up their sitting tolerance. Okay. So the importance of the correct seating setup. So you can have the best equipment available to you, or frustratingly often is out of your reach. As many of us know, the challenges with funding now can become very, very difficult. So that's why even more so, we have to have the best clinical reasoning skills. We have to be the ones pointing out the risks of not giving them correct seating, the damage that's potentially occurring to that individual because they don't have the correct seating. So specialist chair dimensions must be based on accurate individual measurements of the user. So there's no point having the best seat in the store if you haven't taken the time to assess that person properly for it. And call back the specialists that you were working with, the company that you had that seating from, call them back, ask them questions again. Hey, I've got this seat, do you remember we issued it for this client? Well, now that client is no longer using it. I would like to set it up for a different client. Could we have a brainstorming session? Could we have a review? Can we make sure that this seating is right for this next client? It's essential that the chair is set up correctly. Otherwise, the individual's posture isn't going to be supported, and they're going to be vulnerable, as I said, to losing interest in sitting, to pressure injuries, discomfort, and fatiguing too quickly. So the chair and seating setup configuration influences positioning, which will impact the risk of secondary complications. As we've said, it'll impact their risk of compressed internal organs, chest infections, skin integrity concerns. And the risks, if not dealt with, may lead to postural deterioration. And before we know it, we've gone from a simple, all it needed was a proper review and setup, to that person's now not wanting to sit anymore and is too uncomfortable to sit, and has now got a pressure ulcer, a pressure injury, so they can't sit. So it's all a loop that could have been avoided from having the correct setup for that chair for that individual. Okay. So the key thing that we should all be happy and comfortable to do as therapists is take correct measurements. When I've run face-to-face courses, which I've been involved with many of, and I've also worked with companies, training their sales, product specialists into how to take correct measurements and how to understand postural presentations, because so many people don't get it. You cannot take accurate measurements of somebody when they're just sat poorly, slumped in an armchair that doesn't fit them. And if you take measurements of somebody lying in their bed, in their profiling bed, those measurements don't always translate into seating measurements. So if you can do one thing as your best thing that day, today, tomorrow, next week, is it take always best measurements. So this is me on a course. I've blanked out the person's face, but they were OTs, and we were going through what is correct measurements. So we want to get the correct seat depth, which is right from behind the knee to the back section behind their bottom. And that will vary hugely on how that person sits. It's a core skill for an OT and physio and many other people that is rarely taught properly anymore on courses, unfortunately. So we have to have the most two important measurements we can take is seat depth, so femur length, and seat width, hip width. We need a firm tape measure. We're not measuring for a dress. We're not measuring for a suit. We're measuring for seating. If you use a floppy tape measure, you measure around. So I get some measurements in on requests for wheelchairs, and I think, blimey, how big is this person? And then you'll phone back to make some inquiries. What tape measure did you use? Oh, a little, sewing one. No, firm tape measure will give you a proper measurement. I also like to put sometimes a book or a folder or something behind the person's bottom, and that will be the back measurement, and the front measurement is just in the crease behind the knee. So the seat depth is crucial. Providing appropriate postural support is not possible in the wrong size chair. So if you've got poor measurements, if you haven't taken proper measurements, you're not going to be able to provide the correct support. And without the correct measurements, you can't ensure maximum contact with the support surfaces of the seating. You can't redistribute weight evenly. And more importantly, if you've got a rep coming out, how can they do the best assessment if you've not given them good measurements? Oh, we're seeing somebody who's 80, their average size, they're quite tall. Oh, I don't know, they're about 5'4" actually. Yeah, bring something. I know chairs are adjustable. I know good seating offers adjustment. But as an OT, I would never want to phone up a rep and say, yeah, come and see this. I give such accurate measurements whenever I'm doing assessment because I want the best outcome from that assessment to give the best chance for that equipment. So I cannot say enough about correct measurements. Sorry, it's a real pet hate of mine. And also, there's no excuse for not doing it. It takes 5 minutes to do correct measurements. Right, I'll move on to the next slide. So, yeah, seat depth. Another slide of seat depth, that's me at the side there, blurred out a bit, and I was demonstrating correct measurements. So you can see again there how I'm doing. I've got my hand at the rear, and I'm using a firm tape measure, and then somebody else the other side is talking to the individual, and they're just checking they're comfortable, secure, and also taking a lower leg measurement. So a lower leg measurement is important also. So if the seat depth is too long, the user will struggle to flex their knees over the edge of the seat cushion. I know seats are adjustable, but they're often not set up properly if we don't have the correct measurements. So if the seat depth is too long, this will force the individual to slide forwards in the chair to allow their knees to bend and flex. This is all common sense stuff. But so many times when I'm reviewing a client in home seating or in a wheelchair, the key thing that's wrong is the seat depth is too long or the seat depth is too short. So if the seat depth is too short, there will be uneven weight distribution for the femurs, for the thighs, which will increase the risk of pressure injuries again. So a key thing you can do as a therapist is always, is the seat depth correct? And that is often your starting point for being a problem solver, being a detective. Next slide. So seat width. So why is the correct seat width so important? So for a wheelchair, it's common sense, because if the seat width is too wide, that person, if they're going to propel, can't self-propel because they'll be out here and they won't have good alignment for the wheels for propulsion. But in home seating, in static seating, the correct seat width is really important to give lateral stability for the pelvis. Again, pelvis, 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 and the trunk. So if it's too wide, you'll go and see somebody. Not all chairs are equal. Not all chairs are wonderfully adjustable. And then you'll see people with big pillows shoved down them. How often do we see somebody that's got pillows down the side of them? Correct seat width can help reduce heavy leaning or slumping. So we don't want to see somebody like this because the seat's too wide. They'll be trying to reach the arm support, the armrest, so they'll lean over towards it. So if the armrests were narrowed in, they would have good stability for their forearms. Leaning postures are easily preventable, and if not corrected, they can lead to a more complex postural need. So that flexible scoliosis can, if left too long from leaning, can become more fixed in an elderly body, and then we're working with a far more complex presentation. In an aging body or a neurological condition, a more basic leaning posture can quickly advance. Okay, next slide. So giving correct support for the lower legs and feet. So we want to always align and fully support the lower legs and feet to encourage equal weight distribution whenever possible. So there will be complications in many with lower legs, and we see a lot of our clients, end users, service users, whatever terminology we use, with large legs and edema. So this will often limit some of the solutions we want to initially work with. So we need to look at providing future-proofed support for the legs and feet. We want to look at the ability to accommodate for these legs when they're painful with edema, lymphedema. So often the clients will need elevating leg supports and support surfaces that are wipe cleanable, wipeable even, because we know that many of these legs have ulcers that need dressing, and then the support surface needs to be cleaned. We need to be able to accommodate for many additional medical complications, providing the correct cushioning and comfort, because that can be another reason why somebody doesn't want to sit, is they just cannot get their legs comfortable. And angle adjustable foot supports are really important when we have many clients with fixed foot limitations. So we need to make sure that their foot and ankle feel comfortable. So even by elevating the legs, we can sometimes still have difficulties with the feet. So all of from the top of the legs all the way down the legs, we need to make sure that they're well supported, well positioned and comfortable. Otherwise, the sitting tolerance just won't be there. Okay, next slide. So tight hamstrings or contractures, we'll see this when I go and see a lot of people to assess them, and I'm told they're unseatable. In bed, they're unseatable. I will see this little old lady often lying in bed in the fetal position, and it could appear that they are unseatable, but what it will be is that they haven't sat for such a long time, so their hamstrings have become really tight and they've got contractures at the knees. So working sometimes jointly with the physio, we'll assess them in lying and we'll look at their passive range of movement and just check that we can get them out into a seated position. So always be careful with the contractures. So we need to make sure that when seated, that we're working really carefully with angles and that we have foot supports that can accommodate contractures so that we can track back and we can accommodate in the seat cushion and really work with these limited angles to gradually think of it like serial splinting. If any of you've done splinting in the past in your roles, you know we've got a fixed wrist with a tight contracted wrist, and we're not going to go straight to there, are we? We're going to go gradually. It's the same with leg positioning. So we need seating that's future-proof, that can accommodate somebody who hasn't done much sitting. So when their hamstrings are really tight, we don't want that to be the reason that they can't sit out in a chair. We need to have seating that's adaptable for those situations. And we need to be advising that nighttime positioning is crucial. So to go from lying in a fetal position to expecting somebody to sit in a chair without the correct support is not possible. And that's why you're being told they're unseatable. But good nighttime positioning, always thinking about 24-hour postural care and translating that into the needs of their supportive seating. Okay. So this will be probably the most common reason for me needing to review somebody. And it is the most basic thing that we can make an impact on as therapists. We need to just problem solve what we're seeing. So sliding forward, I'll see on a referral, on a review, this client needs reviewing. They can't use their seat. They can't use their wheelchair because they're sliding forwards. They can't sit in it. It's not working for them. What do we need to check? Let's just go back to the basics. And it will usually be that the correct seat depth for the individual isn't set up. So I will go and measure people and I'll do my correct measuring, accurate measuring. If I'm with a colleague, we'll both check it. And if I've got a member of staff there from the nursing home or a relative in the home, I'll say, right, you can see this is the measurement and this is the seat depth. It's too long. So they're sliding forwards because they have to slide forwards because otherwise they can't. You know what it's like at home if you go to somebody else's house, they've got a sofa that's too long for you to sit on. I'm only 5'1". It happens to me all the time. You have to slide forward to be able to sit in that seat, or you have to sit with your legs out in front of you or curl your legs round. It's the same for everybody. So that will be the number one thing, that the seat depth is too long. I just think, who on earth has set this seat depth of? Who was measuring this person? Because that is a basic thing. Correct placement of the pelvic belt. Pelvic belts should be across the pelvis. They should be holding the pelvis in neutral alignment. They should be coming across here at 45 degrees. If they're up across the waist, they're like a lap belt. We're not providing lap belts. We're providing postural pelvic belts to help keep the person in an upright, neutral posture in their pelvis. Correct contour in the seat cushion. If you've got a completely flat seat cushion, what happens to this unstable pelvis? It has nowhere to go. It has nowhere to immerse to. We have to have contours to hold the pelvis in a well. Sling choice. Are they sitting on their sling? Are they remaining on the sling? Often, yes. And that's just something we have to work with. Is that sling sliding on that seat surface? Yes, nearly all the time. Go back to the providers of the sling, that might be you as well, if that's your role, and say, there are other sling choices. This sling is not working. This is the cause of them sliding forward. Are their feet supported correctly? If their feet aren't supported, they're going to slide forwards. Often I'll see people, they don't like the footrest. We've took it off. Oh, they don't want their feet on that. They're not comfortable. We've taken it away. They're going to slide. The seat cushion cover. Is the seat cushion cover the correct fabric? Is it conflicting with the sling? I've said that already. Is tilt needed? The amount of people who aren't given tilt, they're just given an upright static chair. It fits them, it's fine. They're only going to sit in it 10 minutes, then we're putting them back in bed. Of course, they're going to slide. Is tilt being used correctly? How many people don't understand the correct use of tilt, don't use it often enough? And is recline being used correctly? So often recline and tilt are confused by care staff. So I'll often lock off the recline once I've set the desired angle. Tilt needs to be used regularly and often to change the person's position, to relieve pressure, to help with against gravity, and to help with fatigue. If the tilt isn't being used, somebody may slide. Always tilt the seating before they're hoisted in. This is all common sense, I know, but I have to keep saying it again and again and again, especially in care settings. Sliding forwards is the easiest thing to solve, but is the biggest reason that you'll be asked to go out. So please just do your basic checks. Thank you. Next slide. Sorry about the soapbox moments. So desires in seating. So Bengt Engstrom, I don't know if any of you have had the pleasure of going to one of his talks. He's written several books. So this is from his book, one of his books. Desires in seating, but stability so you can relax, freedom so you can move, balance to move between activity and rest, control so your muscles can move and stabilize your trunk, arms and head. Think back to the triangle, the pyramid. Comfort, think back to what Tristan said at the start and what I will always say. Comfort, so pressure and shear are acceptable. Time, you do not want to sit for too long. That is correct. We do not want people sat in their chairs all day long. But also we don't want somebody just in their chairs for 10 minutes and then taken out because they just couldn't tolerate it. So desires in seating. This is an old from 2006, so 20 years ago, but all those points are still relevant and valid. And do we check all of those points when we go back and review somebody, when we go out and assess somebody? Are we looking at what are the desires? What are the goals? What are the aims in seating? Next slide. So why is the correct seating so important? I'm recapping here. I hope you all realise why the correct seating is so important, and that's why you've taken the time to come along and just reflect on this today. So the provision of the correct seating protects body shape and posture and reduces the risk of developing postural limitations. So is it right when you prescribed it? Is it right when you handed it over? Is it right when you review it? You have to review these clients, and you have to have healthcare professionals that are passionate about reviewing seating, or calling the rep back in to review the seating. Work with companies where the reps want to go back out and review the seating with you. They're invested in that seating working, not just at the point of sale, but every other point afterwards. Help prevent contractures developing. We've talked about that. Think of it as we can't solve it today. It's a longer journey. It's a longer process. Inform and work with the carers that are there. It helps prevent slumping, heavy leaning. That's a simple thing that we can correct. Minimize pain. We don't want anybody pain, discomfort. We don't want anybody in that scenario with our name against it. Increase sitting tolerance and reduce fatigue. So 10 minutes of sitting is a huge effort for carers to hoist somebody out. And then you wonder why they're just staying in bed because it took 2 of us to hoist them out. They were in it 10 minutes and then 2 of us to hoist them back. So we're not bothering trying them again. And that's a cycle that happens when our challenged setups have reduced ability for as much care as people need. So we want to optimize participation. That's what occupational therapy is about. That's what life is about. We don't want our elder people, we don't want our parents, our grandparents, our neighbours becoming people that are just lying in bed all day. What is the quality of life for somebody that doesn't have the ability to change their position from lying to sitting to maybe even standing? Okay, sorry, I'm going to soapbox moments again here. Next slide. And what are the risks of poor seating and poor posture? We all should be able to list these with our eyes shut. So decreased function, increased dependency, pressure risk, compromised skin integrity, pressure injuries, so somebody's on bed rest for a month, for a year, however long, compromised internal organs, think of the chest infections, think of the pneumonia, muscle fatigue, risk of contractures, increased pain and poor sitting tolerance, that person that doesn't want to sit anymore, that person that's labelled as unseatable, decreased motivation, that person doesn't feel they have anything to get up for because actually they're lying in bed all day apart from their personal care. They need a change of scene, they need to get out of bed. Reduced quality of life. And quality of life, if we can't improve that as therapists, then I feel that's a really sad day that we're working in. Okay, next. So clinical guidance and education. So it's so important that there's clinical guidance when looking at providing the correct seating. Otherwise, why are OTs needed? You know, if we can just have somebody in a store saying, send that chair out to that person, that'll be fine. Where does that leave the role of the OT? We need to be able to justify why these features and benefits are needed, why tilt's needed, why recline's needed, why these functions can provide the correct solutions. We need to train and educate people that are unaware of the benefits of providing the correct seating, and we need to empower people through education, especially people who are decision makers that aren't always clinical. We need to understand the benefits of dynamic repositioning. So dynamic repositioning means using different functions on seating. We need to understand why we're using them, why we're prescribing them. And we need to have a collaborative approach between clinicians, users, and people who are making the decisions. So that has all been taken from a clinical consensus. So here is the reference for that. So training programs should focus on the practical applications of tilt and recline, emphasising their role in pressure management, postural stability, and functional performances. Okay, next slide. Nearly finished. So conclusions, comfort is individual. I hope we all understand that. That guy doesn't look that comfortable or stable on that chair. That's the best picture I find. People have unique needs. The people we have the privilege to be working with every day, they have unique needs, not one size fits all. Comfort can only be achieved through personalised seating solutions and seat functions. That's where the OT's role excels. I'm not going to read through all of this slide because I think I've said it enough throughout my talk, but don't rule out anything until you've tried it. Even if it goes against all your seating principles, try it. If it makes sense in your head, just think, I'm just going to try that. I'm just going to open up that hip angle a little by using a little bit more recline than I'd normally like to use and see if it works. What's the worst thing that happens? You have to reset it. Be a detective, make the adjustments and make the reviews. It could make the biggest difference to an individual's quality of life by you taking that extra 10 minutes to tweak that chair, to rethink it, to go back to your original goals when you were requesting that equipment. Okay, next slide. That's fine. I finished, so I didn't have to do a next slide. Even better, because my voice is starting to struggle. Over to you.
Brilliant. Thank you very much.
Yeah.
But the webinar isn't over yet. We've got more to share.
Have a break. I can have a break.
You can have a little break. So the idea now is I'm going to just go into our video demonstration room and go through some of the points that Joe's brought up, but try to bring them to life a little bit by showing you an example of a chair that might be used and some of the things that we can do for them. And then following that, we've got lots of questions and comments already on the chat. Please do keep adding those, and we'll revisit those after the practical demonstration at the end of the webinar. Just give me one moment, and I'm just going to pop downstairs into our video room, and we'll get off with the next section of the webinar. Thank you all. There we go. Hopefully everyone can see and hear me. I'll just have a little thumbs up from you, Joe. Brilliant, thank you. Good. So as I say, we're just going to go through one of the chairs in our Lento care chair range, just to give you a bit of an idea as to how we can practically apply all those tips that we've heard from Joe. So this is actually the Lento Cove care chair. This is the top chair in the range, so for the most complex needs, and it's relatively new. Some of you may have seen it at the OT show where we launched it at the end of last year. It's been going down really well because it looks at adjustment and flexibility, but with comfort in mind as well. Now, to start off with, Joe was talking about the importance of seat sizing, and this again is kind of one of my personal soapbox moments. I think really the seat sizing is absolutely key to getting comfort right, but also your pressure care, also your posture. That is really a key part of getting everything correct. It's getting that seat sizing right. Everyone's different shapes and sizes, so it's great to have a chair where you've got those adjustments inbuilt, so you can change those dimensions over time. If someone puts on weight or loses weight, or their postural presentation changes, you might want to tweak some of these measurements, or reissuing the same chair for different clients. Joe mentioned earlier about it's not just about getting a chair from stores and putting it in front of someone. You know, it's key to get those chairs reconfigured to the right size. So seat depth was a key measurement that Joe spoke about, and as she mentioned, if we get the seat depth correct, it means that we can minimize the risk of sliding out. We can improve the pelvic posture. We can ensure that there's enough support all the way along the thigh to reduce peak pressure. So what we've got here on the Lento range of chairs, all we've got is a little pull pin here, which just comes out, and then we've got a handle at the back, and the whole seat and backrest slides in and out. So you can see I'm moving that there. You can see there's a lot of adjustment there for different size people, and that seat depth is critical. So in the same chair, you can get someone from about 5'2" right up to, I think we've had someone of 6'11", and then there's a smaller chair with a lot of adjustment as well for those that are under 5'2". So it's important to know that you've got those adjustments available on the chair. Seat height is often about, when you're in a care chair like this, so this is a tilting space care chair designed for someone that's hoisted. Now, we need to make sure that for someone who's hoisted, the feet are supported. So we've got your foot plate here, and that foot plate obviously can move up and down to suit people with different leg lengths. So another key measurement is your seat height. Obviously, if we were looking at more of a rise recline chair, that would be the measurement from the floor to the top of the seat cushion. But on a care chair where we've got a foot plate, it's about the measurement from the top of the seat to the foot plate. We've spoken about contraptions just while we're on the foot plate section. So this is when you've got someone with very tight hamstrings and their feet are kind of tucking back under their thigh section, we need what we call a negative leg rest angle, and that's possible by just swapping this cushion here and moving the seat cushion a little bit further forward, and then you've got room for those legs to go under the seat. You'll often see this presentation when someone might have been in bed for a long period of time, and their hamstrings have got tighter over time. And a lot of people think, oh, we can't get them into a seated position. Well, with the right equipment, with the right chair, that is possible, and it will hopefully improve over time. Just going to pop those back. So we talked about the seat depth and the seat height, and the other measurement that Joe talked about was the seat width. So seat width might not be quite as important as the other two measurements, but it is still really key. So it's about making sure that we've got the arm support in the right place. Particularly if someone's standing, you don't want the seat width too wide, and they're trying to push up on armrests really far apart. But also a very wide seat width, people want support for their arms. This is where we tend to get kind of leaning to the side to try and get that support, or wind sweeping, etc. So seat width, that's just adjustable with a little screw knob under the seat, and with the arms pull out over the seat, and you can see we can get a lot of different size users in the same chair. So that's the kind of base measurements. In terms of the way the chairs move, we talked about tilting space a lot. So tilting space is, as we know, it's about moving people back in the seat, almost like a cradle, rocking someone back. And again, that's doing multiple things. So we're looking at stopping sliding out the chair. We're looking at getting that pelvis in a good neutral position. We're spreading the weight of the user. So we're spreading that pressure from the seat right up through the backrest, through the head, so that not all that weight is going through the base of the spine, and we're reducing peak pressure there. But in this position as well, we can still see round the room, which I think is really important. If we just kept the seat flat and we use backrest recline instead, what happens is that we end up looking at the ceiling, whereas the tilting action puts in a good position, and they're bringing the weight of the backrest and the head back, but we're not looking at the ceiling, so the quality of life isn't affected. So tilting space, really key measurement, really key kind of action on a chair, and a key of making sure a chair's future-proof. Even if they don't need the tilting space now, the chances are they could well need it in the future. Another point I wanted to cover off was on our new Lento care chairs, which is obviously the one I'm showing you now. Joe mentioned about not having a flat seat, and this is something that a lot of people think about. A lot of people haven't really considered as much. If you've got a flat seat, what's the shape of our body? What's the shape of our bottom and our thigh? Well, it's not flat. So first of all, it's a comfort point of view. But secondly, as Joe said, it's about supporting that pelvis in a neutral position. And if we've just got a flat seat, then we don't have that kind of well for the pelvis. So that's why we've started. It's quite subtle here. You can't see it. If you were here, you could probably see it better. But we've got like a raised section at the front of the seat, and as the cushion goes back, it drops down into a bit of a well, so that your pelvis is held in a good neutral position. It's helping with pressure care, helping with comfort, and helping stopping sliding out. So all these measurements, actions, adjustments, the seat cushion, all of those are available across all our Lento range. But the one thing that's different on this chair, which is called the Lento Cove, as I said, this is the top chair in our range for those with the most complex of needs. And the bit that's different about the code is this section here, which is obviously the backrest. And what we've got is over 2 quadrillion different different configurations that this backrest can go through. So we've got at each point on each arm, we've got 1, 2, 3, 4 adjustments. So we can really move in the arms in and out to give pelvic support, trunk support, and also head support. We can also move them side to side. So for scoliosis, which Joe talked about before, we can get the shape of the backrest right for that individual. We've also got height adjustment on all of these because obviously everyone's different proportions, different sizes. So there's loads of adjustment. But I think what's different about this, you might have seen this type of kind of adjustment on other chairs, other care chairs out there. But the difference with this one is that on the front of these arms, we've put a very soft kind of Dacron filled, almost like a pillow, a bed pillow. You've got all that softness there. So as Joe mentioned earlier, you need a bit of room for the backrest, particularly with kyphosis, that kind of thing. You want comfort as well as support, and it's about getting the two balanced correctly. You know, we often see, don't we, with kind of like a metal support that comes around from the side, and yes, we're giving really good strong support, but over time that can actually cause pressure damage itself. And if we're really thinking about comfort being the key thing in all of this, well, is that the most comfortable thing for the user? Probably not. So this is what we've tried to do with the Lento Cove Care Chair, is provide that support for different shaped people, no matter what kind of spinal and postural presentation you've got, but giving that comfort at the same time. So comfort and support. So this just is one of the chairs in the Lento range. Do have a look at the website. There's loads of different options, loads of accessories. There's a lot more about the chairs than I can go through in this presentation, in this section of the webinar. But for now, I'll just pop back to the room upstairs, and then we'll go through. I know we've had quite a few questions. Please do put them back on the chat whilst you're waiting. And we'll answer those in a few moments. Just bear with me. Thank you.
Reading through some of the questions, so trying to catch up with them all. Thank you for the lovely comments. I've tried to respond to all of them with a heart. So, but yeah, appreciate that. It's really hard pitching to lots of different people who you don't know, and also to lots of different experience levels. So I've tried to include some basics and then to answer some solutions. One of the questions that I did see was about when we're accommodating for contractures, would you then put support behind somebody? So I think what's been asked here, so when accommodating for contractures or tight hamstrings was the scenario I gave with the picture, it's no, you're not reducing the seat depth. You don't need to do that. You still need to have the good support and correct seat depth, because it's actually not their leg length that's any shorter. It's their range at their knee that has changed in this particular instance. So there's a couple of ways of tackling this. It might just be sometimes that you need a little bit to choose your support surface correctly with the base cushion. So a cushion that will can be sculpted back a little bit behind the tight contracted knee, to just give a little bit of space for that leg to come back. And more importantly, it's about the foot support being able to come back to angles, to give angles greater than 90. So if you're trying to support somebody's lower leg at 90, actually, but that's not where their foot can comfortably sit because of their contraction at the knee, their foot isn't going to be supported, and they're going to be pressing hard against the back of their leg. So we need to make sure we can accommodate the tightness in their knees is important. We're not necessarily reducing the seat depth. So we're just making sure that the front of the cushion is forgiving enough, soft enough to accommodate that tightness against it. And also, the more important, that the feet are supported and you've not just got them dangling and allowing the person to pull even tighter into that contracture. It could be due to tone, or it could be due to shortened hamstring length, because when we've got shortened hamstring length as well, if we don't accommodate it, it also pulls the pelvis into posterior tilt. So probably didn't explain that well enough on that slide. I was getting a bit rushy with my timing, so hopefully that answers that. Okay.
Thanks, Jo. That's really helpful. Thanks for getting stuck in on the questions as well. We've got quite a number here, so I'll just work through some of the other ones. We've got some with regards to measuring, if measuring on bed / in chair is the only option to measure, how would you ensure accuracy?
Yeah, so that
question
is
from Rebecca there.
I know I showed these. The ideal is to have two people, which isn't always possible, is it? And then to I'm working often in a scenario where I have a plinth in a clinical room with a plinth. You're working in people's homes, often in the community or in care home settings or wherever. So you won't have that luxury. So I was showing the ideal would be taking the time to hoist somebody onto a plinth to take good measurements. And the perfect would be to look at them in lying for measurements and sitting, because then you can see what is fixed and what is correctable when you look at them in lying versus in sitting. But that is the ideal, that is the best scenario. But in real life scenarios, it's just about really taking time to do good measurements. So one good thing that Tristan showed in his demonstration to show the contour of the cushion, if you can just take the time and get somebody to help you if you don't know how to do it, to remove the arm, if that's possible, then you can really look at the side and think, am I measuring correctly? Because if the person is seated, keep holding this pelvis again, with their pelvis rolled back into posterior tilt, it will make it appear like they've got a much longer seat depth than they actually have. Because what you're measuring is their leg length to the back of their bottom. But if their pelvis is rolled back, it can give you like 3 inches extra on seat depth than what's actually accurate. So when they're at the correct seat and you've got support behind their sacrum and you're blocking them so they don't roll back, then you'll realize that actually I've measured them 20 seat depth, but they're only 17. So look at the side, take the arm off if possible, get your arm up the side, feel, is there a gap behind their bottom? And often you can see there's a 2 to 3 inch gap behind their bottom because they've rolled into posterior tilt, they've slid forwards. What I also like to use is a slide glove, because you can, when a seat is tight or when somebody's feeling discomfort, it helps your hands slide up the side of them and behind them. If I can get my hand behind somebody, they're not properly back. Sometimes I can get a whole fist behind. If you think somebody's bottom's there, I can get a whole fist behind them. And if I'm measuring from the back of the seat to the front behind their knee, that isn't their measurement, that's that seat's measurement. So we've got to think, I'm measuring that person's body to go into the correct seat I want to put them into. I'm not measuring the seat they're in now and how they present in it. I'm measuring what I want them to present like in the correct seat. So often, if you can slide your hand in behind, you don't want to take that measurement because that measurement of your fist is another 2.5 whatever inches, and you're adding that onto your tape measure measurement. This is a really common problem. So if you can't get them out onto a plinth, which isn't always possible, do really accurate measurements in the seat. To answer about measuring the person who's lying on an air mattress, I read that one as well. That is tricky, and I'm in that scenario quite a bit myself when I do home visits. again, work with another person. Don't try and do those measurements on your own. If you've just got a carer there, pull them in and say, I need you to help me take measurements because I'm going to try and support this person. So in lying on their back, so in supine lying, I would then try and flex their hip, because it's good to see what range they've got at their hip anyway, and hold their leg up. So I'm doing a seat depth measurement with somebody holding their leg for me. I'm measuring from the base of the bed. I know it's an air mattress, measuring from the base of the bed up to where their knee bends, and that will be your seat depth measurement. So you can do a more accurate measurement in lying with the support of another person. You're not going to be able to do that on your own. You can't hold the weight of that leg. Somebody who might be in a lot of pain, somebody who's scared of being moved, and do a good measurement. Get somebody to help you. Always ask for help. Just say, I'm going to need a member of staff. You don't need to be clinical. You just need to come and support this person, hold their leg so I can get a good measurement. Okay.
That's helpful. Thanks. Joe, we've also had a comment on the chat, I noticed, which is very true. Some of the mattresses have like a static kind of setting, which is often used for transfers, like lateral transfers, that kind of thing. Well, yeah, if it's safe to do so, you've got space to do your measurements on. Just following on from that type of question, we had another question as to if the patient is hoist transferred and struggles to maintain sitting support, would you measure them in the seat or hoist to the edge of the bed with full support from staff, or another way? So over to you.
I do both actually. I have measured somebody on the edge of a bed but you've got to have good support. And if I'm working with another therapist, sometimes it's a joint visit. Because if somebody needs hoisting is more complex, it'll often be done as a joint therapy visit, or a therapist and a health, assistant practitioner. So yeah, if you can look at somebody on the edge of the bed safely, and it could be leaving them in the sling as an extra security thing as well. You can take quite nice measurements there, and you can also see what they're like in sitting, because back in the day when we did a lot of hands-on therapy and we used to sit people and do sitting on plinth practice, and all of that lovely stuff. That was normal what we did then. That was a typical day's clinical work. But now for the pressures, it doesn't happen so much. But either hoist them and measure them in a chair, whatever chair there is available, the best chair you can get, or on the edge of the bed when it's safe to do so. Both can give a good outcome. Yeah.
Thank you, Joe. Probably should just mention at this point that we've just got 6 minutes left. We've got a lot of questions on here.
Sorry, I'll shut up because I'm too much rambling here. It's me.
I think we are going to struggle to get through all of them, to be honest, but we'll see what we can do in our few minutes left. So we've got another question here. What are your thoughts on providing a comfortable postural supported chair for relief from a molded wheelchair, usually provided by a few hours in bed in the late afternoon, considering reducing restriction but preventing pain or potential contractures?
So I think the question is, if somebody's got a specially moulded seat probably from a wheelchair service, what are my thoughts on alternative seating as well? Definitely. So I would say, and this is a strong message I give within a wheelchair service, is that it's a mobility device. It's not something to be sat in all day. So you're not really, unless somebody's got absolutely zero sitting tolerance and balance and they're only safe in their molded seat, okay, continue. But usually most people will benefit from a supportive chair with the correct postural supports and correct functions, tilt, recline, etc., elevating legs. They will benefit from that as a change. It isn't going from one seat to another seat is a change of position. So bed to the wheelchair, that's one position. Wheelchair to a comfy chair for it in a social situation is another. So if somebody's sat in their molded seat for too long, that won't work well either, because they would just be too uncomfortable from the lack of change of position. So I would always advocate for that.
Yeah, and absolutely, that's the key kind of situations that we use the Lento Cove chair for, because you've got ability to make it almost a bit like a molded seat. So you've got kind of adjustment, you can accommodate those complex shapes, but it's looser, it's softer, more comfortable. And we often find someone that's in a model day, at the end of the day, they might just want to spend a few hours with the family in the lounge. They're in comfortable seats, they want to be comfortable as well. And as you said as well, you're coming out of a very fixed kind of molded seat and you're changing their positioning, and that's always a good thing. I'm sure that the assessment in the first place is correct. So fully agree on that one. Another question here: how can this be transferable in the community hospital setting? We have limited seating options such as a tilting space wheelchair and a tilting space care chair. Can reps visit ward and provide lone seating on the ward? For discharge purposes, we have access to wheelchair referrals, but not static seating. So great question, and something that we work with a lot. We work with hospitals throughout the country, and yes, we do hire out chairs. We do supply a lot of chairs through charitable funding, that kind of thing as well. And absolutely, it's important to try and get people out of bed reduce that deconditioning, and bring them into a seated position so that we can help with rehab and we do provide chairs for trial as well, so that justification. So I think hopefully that covers off that one. Another question here. Speaking as an aspiring OT with cerebral palsy, as a reasonable adjustment, I couldn't take the measurements myself. Could I train a PA alongside me to be able to support me in my practice to take the measurements on my behalf?
Definitely.
Interesting one. Yeah.
I read that comment and I absolutely loved it. I think it's wonderful that you are an aspiring OT with your own needs, but doesn't stop you being an amazing OT. And actually, because you've got the lived experience, you will be the best OT out there. I can believe that. So no, you can guide somebody and direct somebody to take the measurements, and there's many ways to help with that. So definitely, but you're the one saying no, retake the measurement. No, could you check it from there? So you're the clinician that knows how you want the measurements doing. It's just that you can't physically do them yourself. So that's a definite yes.
Very good, thank you. We've got a few questions with regard to transfers using rotunda, mobility aids, that kind of thing. There are chairs that do that. If you are using kind of steady or a return, that kind of equipment, I'd recommend that you have a look at the Lento mobile chair, which is kind of a cross between a care chair and a rise recline chair. You can use that with Sarah Steady and other equipment, but you've also got the rise action if you need that. But you've also got wheels, so you can wheel someone around. You can use a hoist with it as well. So good one to look at on the website. Mobile chair. I think last question, which is always an interesting one. Sorry, we haven't had a chance to go through all of the questions that everyone's put on the chat. Thank you for the engagement there. But we've got a question here to the old debate: how do you justify the use of lap belts versus restraint? So very common topic, this one, isn't it?
You almost need a webinar for this. So it's a very difficult one to answer. It's also about capacity as well. So it's a daily thing that I have to deal with in different roles. And if it's to benefit somebody's posture, to keep them in the best position to protect their body shape, and without that, they can't sit safely in that seat, it is a postural element, a postural accessory. If it is to hold that person in that chair because you don't want them getting out of it, it's a restraint. Same as if somebody's tilted back fully because you don't want them to get out of it, that's restraint. So I see this all the time, and it's such a huge topic that we all need to be very responsible about, and we all need to report it when we see restraint used rather than a postural support. And sadly, you do see it a lot when you're out there. But correct postural accessories, correct pelvic harnesses that are there to aid postural support are crucial and needed, and will be the difference sometimes between a piece of equipment working and not. But a lap belt used or a harness used to hold somebody in a seat is completely different, and you need a DOLS in place because that is restraint. And I could do an hour on this.
So absolutely. It's one of those topics that there's a lot of passion about. It is very much about cognition and, what's their cognition like.
But I would say, can that person sit safely, upright, supported without the harness? Yes, they don't need it. It's not a postural accessory. It is a restraint. It's not a transport accessory either. Be clear on that. Sorry, we're talking wheelchairs, not static. And the same with the pelvic harness. If the person doesn't need it to help keep their pelvis in there, to help them keep aligned in the position you want them in, then they don't need it. If you're keeping it there to hold them in the chair because you don't want them getting out, that's a very different thing. So think posture. Is it needed for their postural support? It's a postural accessory. It's not a restraint.
Well, I think we've probably used up a bit more time than we've got available. So 3 minutes over. Thank you so much for joining, everyone.
Thank you.
Please do look at our website, www.vivid.care. There's loads of further information on there, including justification templates, other webinar recordings, loads of downloads, seat sizing forms, all sorts of things that really feed back into what we've discussed here on the webinar today. There will be more webinars coming up, so keep your eyes open for those. And if you do have any specific client questions, please do email them across to us, enquiries@vivid.care, or give us a call. We'll be really glad to help. Something that we do a lot of, the specialist seating, something you've hopefully seen we're very passionate about, and we do offer trials, demonstrations, further training, and also individual client assessments as well. Thank you so much again for joining. Have a brilliant rest of your day. Thank you.
Thank you.